Thanks for listening to the Lunch and Learn with Dr. Barry, here to help educate, motivate, and put you on the right path to take control of your health through weekly discussions on topics in the medical field, public health arena, and in your community. And now your host, Dr. Barry.
And welcome to another episode of the Lunch and Learn with Dr. Barry. I'm your host, Dr. Barry Pierre, your favorite board-certified internist, founder of drbarrypierre.com, as well as the CEO of Pierre Medical Consulting, helping you empower yourself for better health with the #1 podcast for patient advocacy, affirmation, and education. This week, we are talking about an extremely important topic, an extremely common topic, which is urinary incontinence. And again, of course, I would not do it any justice if not bringing on a specialist in this field. And I've got one of the more famous ones, especially if you follow her on social media, Dr. Fenwa Milhouse, who is a fellowship-trained urologist who specializes in female pelvic medicine and urogenital reconstruction. And the thing I love about Dr. Milhouse is one, again, you know, I have an affinity for physicians who love to use their platform as well as their expertise, especially in this day and age of social media, to help educate. And she loves to do that. She's very passionate about telling young people about urology, mentoring them, especially underrepresented minorities in the field of urology. And we're going to talk a lot about what it means to be underrepresented, especially when we think about urology. It seems like it's a very male-dominated topic, right? Like you think about prostate and those things in that regards, but understanding that the topic at hand, urinary incontinence, affects women much more than affects men. But unfortunately, when women are going to look for a doctor who can treat these problems, guess what? 9 times out of 10, right? And honestly, probably 9.5 times out of 10, they're going to see a urologist who is a male and not a female, not someone who may be able to relate. It's very, very disheartening, especially as a physician who, you know, I got to talk about this all the time. You know, I know when I have my minority patients who see me, especially my African-American patients who see me, and, you know, I can see a difference in their eye when I'm the one who kind of walks into the room, right? Because again, they're so used to probably not seeing someone who looks like me. So being able to see someone who looks like me is definitely a benefit, right? So imagine, you know, being women, right, and having these urinary incontinence problems, right? We're going to talk a lot about, you know, how common it is, you know, what are the signs and symptoms, what are the treatment options. We're going to get to all of that during this episode. And again, it's a sight to see, right? And again, I'm just thankful for having Dr. Milhouse and being able to kind of educate us as well as, and you know, again, I say this all the time. A lot of times when I bring these guests onto this show, I'm learning just as much as you guys are learning. So I'm definitely thankful for you know, you guys' support here in the Lunch and Learn community, for being able to rock on and you know, support all of our guests who come on the show. So again, I'll stop doing my long talking. Let's get ready for another amazing episode here on the Lunch and Learn with Dr. Barry. This podcast is sponsored by the Lunch and Learn Community Merchandise Store, living out the motto, empower yourself for better health. At the store, you can get your favorite t-shirts, coffee mugs, even wristbands, and more. For a limited time, you can get 10% off your next purchase using the coupon code EMPOWER10. That's EMPOWER10, EMPOWER10. You just go to shop.drbarrypr.com to pick up your purchase and get 10% off today. And remember, 50% of your purchases will be donated to the 5-Star Scholarship Foundation, a nonprofit organization for high school students. All right, Lunch and Learn community, you are in store for another amazing episode today. I had the pleasure of being able to welcome an esteemed urologist, and you know, it's very difficult to get them, especially difficult to get them on the show. So anytime I get a chance to kind of educate you guys on all of the urinary issues that I usually have to refer out, I'm definitely blessed, and you know, she took the time to kind of come on and you know, pass some of her knowledge on to us. Again, Dr. Milhouse, thank you for coming on to the show.
Thank you so much for having me. It's my pleasure to talk about something that I treat all the time, that we all treat. You know, I know you see this all the time as well, that Dr. Barry, that doesn't really get a lot of attention. So
100%, especially from as an outpatient clinical physician. Before I went into the hospital setting, it was one of the more common complaints. Mm-hmm. And, I throw a couple of medications here and there, but my end goal was like, yeah, you're probably going to have to see a urologist because this is kind of really what they do. Like I can help when medication can't help, but sometimes medication can't help. What you got going on. So that's why even when I prescribe said medication, I always give that referral off because hey, this I know what I know and I know what I don't know. Right.
Important to know what you don't know. That's very important. The most important.
100%. I tell my residents all the time, like, guys, I don't care how smart you are. If you don't know where your limit ends, you're gonna be in trouble, right? And
agree.
Someone's gonna get hurt. So we never want that to ever occur.
Yes.
So, Dr. Milhouse, if I gave him an introduction about what's going on, but like as far as especially let's say I have a lot of people who like to skip the intro and like go straight to. I don't know why they do it. And what's worse, I literally say this every episode and they still skip right over. So I'm just trying to. I'm trying to pass forward the commercial and everything. We'll just get to the main episode. Tell them a little bit. May that be what in your bio about yourself and who you are and how you got to where you're at today.
So I am a urologist. Obviously, I work in the Chicago area, a big private practice group called Dupage Medical Group. I did not even know what urology was until I got to medical school. Didn't even know that a field existed. That was urology. And when I heard about it, I didn't think anything of it. That's not me. Why would I want to do something that tends to be more on the male sexual medicine or reproductive side of things? I mean, obviously urologists do a lot of urinary tract, which is both men and female. But anyway, long story short, I saw a Black woman urologist. I met. She gave us a lecture and it changed my world because I saw myself in her and I thought, wow, if she is a passionate urologist, I want to figure out why she went into this field and why she loves it so much. And from then on, spent a lot of time with different urologists that were all wonderful to work with. And I loved what they did. We deal with a lot of quality of life issues that we get to really get to have a relationship with our patients because we're discussing a lot of things that are embarrassing that they wouldn't tell anybody else. And I like that part of what we do. We do obviously a ton of surgery, which I love. But we also do a lot of medical management in the office, which is enjoyable too. So I'm here to show my passion. One of the main things that I do is incontinence because I am what we call FPMRS urologist. So FPMRS is a subspecialty of urology, and it stands for female pelvic medicine and reconstructive surgery. Now, urinary incontinence obviously affects men and women much more than women than men. But FPMRS specialists can have may have more skills to treat the harder to treat cases, that of incontinence that we get. So, as an FPMRS subspecialist, I deal with probably 50 to 75% of my practice is incontinence.
Wow. Okay.
Yeah.
and that's so very interesting. Like I said, we kind of alluded it to before, especially as a primary care, kind of the front lines where I typically get a lot of these symptoms. I didn't realize that you can really have a practice that only focuses on just that aspect.
Oh, yes. So there's estimated 33 million people in the United States that have urinary incontinence. Probably more. Probably those numbers are underreported, but that's a lot of people out there that are suffering from something and need help.
So for the Lunch and Learn community members out there, let's talk about what urinary incontinence is. Like what does that even mean to someone? And when would they know? Like let's say they don't have a doctor like me who always sends them to a urologist. When would they know to even go to see one?
So urinary incontinence is any unintended loss of urine or leakage, okay? And it could be as little as a drop or two, or it could be a whole, complete accident, soaking your undergarments, running through diapers or pads or soaking the bed. And it can happen day or night. Urinary incontinence has the one factor that I find is misunderstood in both patients and in non-urologists is that urinary incontinence is not one cause. Just because you leak urine doesn't mean that there's just one aspect of it, okay? when we think of urinary incontinence, think of it as, is the bladder doing something it shouldn't? So it's contracting or losing urine, not when it's, it's causing you to lose urine or have an urge that you didn't intend. Or is the sphincter? The sphincter is the set of muscles that hold things, from coming out. So it's, outside of what we call the bladder opening is a sphincter in men and women. And is the sphincter not doing something it should? The sphincter should hold in urine when we don't want to urinate, okay? So it's either the bladder doing something it's not supposed to, or the sphincter not doing something that it's supposed to do, or a combination of both. And so the different causes of urinary incontinence are extremely important to know how to treat a patient, because certain types, depending on the type, you might be getting a treatment that is completely useless to you because somebody may not understand that this is not the type of leakage. For instance, one thing I see all the time, and I'm sure this isn't you, Dr. Barry.
Hey, lunch you can't see me, but unless you're watching the YouTube video, I'm smiling because in my mind I'm like, ooh, I wonder if I'd be sending.
So one thing I see all the time, and I educate my patients and fellow colleagues, is a patient, let's say a woman who's had a few kids, and she says, every time I go for a run, or every time I'm in the gym, or every time I cough, I leak urine. It's been driving me crazy. My doctor gave me these pills. They didn't work. What can you do for me? And I'm saying to myself, okay, this is the wrong indication. Pills don't work for this type of leakage, which is called stress incontinence. And that's more of the sphincter not doing what it's supposed to do. Activity is inducing the leakage. So medications which are geared for the bladder is not appropriate to use for that type of leakage. Okay. So then I have to tell patients, okay, well, yeah, that's why medications were never going to work for you, because you have a different type of urinary incontinence and we need to do this. Very, very, very common example.
It's so funny because in my mind I was like, I wonder how many referrals she gets. With the doctor sending them like, oh, hey, I've given all of the medications and it don't seem to work. I'll let you.
So yeah, and then what was the other part of your question? You said what is incontinence?
Just in regards to, and I guess you kind of answered as far as like, when would it be time to see a urologist? Like,
oh yes, yeah. So I think it's perfectly appropriate for patients to try a medication or to go over behavioral changes with their primary physician. In general, things, the behavioral aspects, especially, those are good habits for anybody, so avoiding the triggers, coffee, tea, soda, those things, practicing maybe Kegel exercises, which we can talk about a little bit later. But when it would be appropriate is if certainly a medication, you've tried one or two medications and it doesn't work. I would not go through the gamut. There's probably I think there's 5 to 7 of these medications. Don't go through the gamut of these whole medications before you send a patient to a urologist. I think after the first, and certainly definitely after the second medication, if you've tried 2 and it doesn't work, please send a patient to us. If a patient is the stress incontinence category, like cough, laugh, sneezing, exercise, running, jumping, it's probably best to go ahead and send that patient right away to urology anyway. Because you can't, again, that's the type of patient you wouldn't prescribe a medication for. So, and I have no problem, if you don't feel comfortable, if you'd rather just us go through the, figuring it out, send them our way from the beginning.
I got some colleagues like that too. They're like, oh, yes. I don't even deal with that system.
Yeah. Let's, if it's not straightforward, absolutely send it to us, right away.
So, and you talked about some of the causes. You obviously mentioned pregnancy. Like, what are some other
risk factors? Yeah. So, risk factors for incontinence. So, first of all, women, just by being, our urethra is shorter, and our sphincter is less robust, if you will. Women being a woman is a risk factor. Women have a higher prevalence of incontinence than men. Probably about 50%, maybe up to 50% of women have experienced incontinence in some form, and maybe the numbers are hard, but 10 to 25% of men. Okay. So women, pregnancy is a risk factor, particularly for the stress incontinence. And let me just stop by saying stress incontinence, I've said multiple examples. The other type is urgency or overactive bladder incontinence. And that's the most prevalent one in both genders, where you kind of suddenly have a strong urge that you can't hold back. And you find yourself like I tell patients, are you doing the pee-pee dance on the way to the bathroom? Are you like leaving a trail behind you? Or are you having an accident like completely on yourself? So pregnancy is much more of a risk factor for the stress incontinence. Weight gain can be a risk factor. So being overweight, diabetes can be a risk factor as well. There are previous pelvic surgery or previous prostate surgery. Obviously prostate surgery is only happening in a man, but that can be a risk factor. So previous pelvic surgery. Neurologic conditions absolutely can be risk factors. So patients who have a history of multiple sclerosis have a high proportion of those who have incontinence. Patients who've had a history of stroke, those patients are at higher risk of incontinence. Parkinson's, dementia, higher risk. So we see a lot of those patients as well.
And it sounds like within your questionnaire, especially when they're first time they're coming to see you, this is kind of the checklist that you're kind of going through to try to figure out, hey, which way do I need to go with this patient in front of me? 100%.
When I first see a patient, I get them to tell me what their problem is in their own words. What is happening? Oh, I leak when I, have to go to the bathroom. As soon as I wake up, I have to run there. I want to get them to say it in their own words. And I tell them, what bothers you the most? What is the aspect? Because some patients will have both issues. They say, well, we have to run to the bathroom and I don't make it. And some patients will say, well, when I cough or I go to the gym and I exercise, that also makes me leak. And the most important question then becomes, what bothers you the most? Because it's the most bothersome part of their symptom that you need to start with first. Okay. This is quality of life that we're talking about. Then I obviously go through their medications and their past history. I'm really focused on like if they have any neurologic problems. Again, if you had a stroke before, you have a history of multiple sclerosis. Have you had back surgeries? Sometimes back or spine interventions might potentially point to a risk or a cause. Previous pregnancies, what treatments have they already done? If they've already done things, let's not start, let's
redo them over.
Let's move you forward. So
from your history, and I talked about this a lot with my residents, but like from a historical standpoint, are you able to get by that time usually enough information so you know which route to go, or are you still having to do like tests, right? Because I think that's what question my patients always ask me. Well, what are they going to do? Like they always want to know what you guys are going to do. Like that's always again. And I've never been a urologist. I don't know what y'all do within the clinic, but for some reason, a lot of people are a little bit afraid to go. So it's always like, what are they going to do when they go over there? Like, yeah.
Oh, great question. So it's kind of funny because now in current COVID environment, I'm doing a lot of these consults via, not FaceTime, but electronic
telehealth minutes.
So I will say this. You can, in most patients, some of scenarios are different. In most patients, you can tell which type of leak or which way you're going to go just by getting a thorough history, especially if you just let the patient talk in their own words, like this is what is happening. Okay. So most cases I can say, okay, well, that person is urgency or overactive bladder, and that person is stress incontinence. Okay. Now, we do like to do an exam. I do like to do pelvic exams, and it's a quick pelvic exam. It's not usually painful. It's not like a gynecology exam that's, might involve a pap smear. It's a very quick pelvic exam. I'm just looking for what the external area around the urethra looks like. If you have cough, flap, sneezing, leakage, I'm going to want to see it on exam, so I have patients cough in front of me and to see, okay, are you leaking? We also do what's called a bladder scan most of the time in an initial consult for sure. And what that is, it's like it's a painless, like little mini ultrasound of your bladder. And it's not even showing pictures. It's just giving us a result of how much you retain or don't retain after you urinate. So we ask you to pee, and then we measure what you leave over. And that can give us some information just to make sure that there isn't also another problem of the bladder not emptying and it's contributing to your leakage in some kind of way. So, but most of the time we can already figure out which way to go just by very thorough history.
And I can tell you, especially for the men who listen to the podcast, they are letting out a sigh of relief because, and again, I get the same issues when I try to have to send them to like gastroenterologists too. They always feel like some invasive test is going to happen. Like that's always their big fear. And I'm not sure what your breakdown is as far as the gender of patients you typically see, but like that's just always a fear for men, right? Like if I gotta go somewhere, does something have to get stuck somewhere? Like that's I gotta be honest for them. I'll ask the questions for them because I know that's what they're thinking. That's the frequently asked questions before I say, all right, I think you need to go see the urologist. Like, well, do they have to stick something up there? And then
we don't have to do a prostate exam for incontinence for the men.
All right.
Now you might get a prostate exam for other reasons. So, yes.
That's too funny. So, I guess that kind of leads me, like, what type of, I know you kind of specialize in your practice, like breakdown gender-wise, are you seeing, is it just because of the sheer numbers of more women having it? Are you seeing more women in your practice, or how is that?
Okay, so because of my gender, I'm a woman urologist, and women want to, ideally, if you give them a choice of here's the male urologist and here's the female urologist, which one do you want to see? They're like 9 times out of 10, they're going to want to see the woman. Okay. Mm-hmm. And so that increases my proportion.
Do you get the inverse as well? Like people are like, oh, I don't want to see.
Sure. There's definitely, I will say the women tend to be, I love my women. They tend to be more biased than the male patients. Male patients, they're a little bit kind of, a few of them are a little bit, admittedly uncomfortable at first, talking to a woman urologist, about these things. I treat the other aspects of urology. So erectile dysfunction, that tends to be where, men might be really kind of, uncomfortable at first. But they're, tend to be kind of go with the punches. Okay. If you're a urologist, so I trust your judgment. Women, it takes a little bit more time to gain their trust, I think. And it might be easier for a woman to do that. I tell my women patients, listen, go to a urologist that you feel comfortable with. It should not be based on their gender, okay? Because I know really, really amazingly smart women and men urologists who do what I do. So, but I do see more women than men, yes, because of my subspecialty, because I'm a woman in the field. And because incontinence, again, which is a large part of my practice, ends up being more prevalent in women.
And I definitely want to talk about this later, just being a woman in your field.
Yeah.
So we'll definitely, especially black women in your field.
Yeah,
we'll definitely touch on that aspect as well. And so you talked about the different types. Now, is it possible? Again, I get this question too. Is it possible to have both? Right? Like, is it possible for medications to work, but you still have the other one where medications don't work?
100% completely possible. In fact, I would say probably especially in women. So in men, the most prevalent type by far is the overactive bladder or urge incontinence. That probably affects, of all the men who have incontinence, probably 50 to 80% are purely, of that variety, if you will. The other type of incontinence, the stress incontinence, like cough, flap, sneezing, exercise, induced. That is much less common in men. The single biggest risk factor in men for that type of incontinence is previous prostate surgery. So we see when I see men who have that, I would say most of those patients have a history of either prostate cancer and having treatment for that. We know the treatments for prostate cancer increase the risk of incontinence, or they've had some sort of prostate procedure for, benign condition, or they've had a pelvic surgery, like a radical surgery for rectal cancer or colon cancer. So that tends to be a specific subset of patients. In women, they are much more likely to have the combo, like you're saying, where they have both types. And then again, that's when that question, what bothers you the most, is the most important. Because if a patient is most bothered by their urgency overactive bladder, but then I do something to treat just the cough, laugh, sneezing, they're still going to be quite upset and bothered. So we really need to listen to the patient and treat the thing that bothers them the most, even though the other thing might be the easier one to treat. The minor one might be the easier one to treat. We need to treat the thing, listen to the patient, treat the patient, not what you see or what you want to do. So yes, 100% you can have both. And I'm very intentional about educating my patients on these two types. I tell them, because I want them to understand why we're doing things, why we're doing these in a stepwise fashion, why I'm not doing something, but I'm doing this. This is because you have these two types. We have to treat this type first, and this is the ways that we're going to treat this type. So ignore the other type for the moment. We'll get back to that other type later. And, I will tell you, if I had all my, 10 of my patients lined up, they would say, yep, that's her. That's what she says. So, yes.
So when you get to that point when you're like, all right, I know which one we're dealing with, right? I've got the history, I've got the symptoms, I've done the inpatient room testing, and now I know I need to treat. What are some of your treatment options? I know we talked some medications on one side, and what are some of the treatment options that are out there?
So for overactive bladder urge incontinence, which is by far the most prevalent one, it goes in there's a stepwise fashion. So we start with behavioral changes and recommendations. That means cutting down or cutting out your coffee, your soda, your tea intake, monitoring your fluid intake. That means going to the bathroom. Like, let's say you're somebody who kind of waits too long to go to the bathroom. That means, okay, now I want you to go to the bathroom maybe more on a timely fashion, every 3-4 hours. That means maybe working on Kegels, where you use those muscles in our pelvis that support us to, incorporate that and get that stronger. So those are the behavioral modifications. Then we will consider medications. These medications, there's a large many of them. And so we might try at least 2 medications. I usually don't try more than 3, because after that, it's unlikely that medications further, the 4th and 5th and 6th one will work. So I try to move patients along. And then beyond medications for overactive bladder, this is where a lot of patients and physicians that aren't urologists don't know that there's actually more out there. So there are 3 FDA-approved treatments beyond medications for overactive bladder. There's something called posterior tibial nerve stimulation, or PTNS, and that's where, interestingly enough, the posterior tibial nerve, which is in our ankle, can get stimulated. And this is a branch of the sacral nerve, S3 nerve, yes, that helps control our bladder. So by stimulating this nerve in your ankle, which this is a very minor office procedure, if you call it a procedure, it's like, basically you sit there and read a book and you get this acupuncture, thing for 30 minutes. But by doing that on a regular basis, that can help control the bladder, believe it or not, in a proportion of patients. So that's an FDA-approved treatment. Another FDA-approved treatment is Botox injections in the bladder. So Botox, everybody knows about Botox. Obviously, cosmetic Botox is out there, but Botox is indicated, has 8 or 9 different indications across the medicine. And one of them is overactive bladder. So we can deliver Botox injections through into the bladder through a camera, and we can do this in our office. And Botox can help control a significant portion of patients who have overactive bladder. And it's something that if it works usually for about 6 months. So they, I tell patients like going to the dentist. If it works, come twice a year, get it done. It's a, quick office visit, go on about your day. So that's an FDA approved treatment. And then
is there any pain with that? Any pain with
it's not painless. It is not painless. We do try, you can numb the bladder up by put a catheter in the bladder, and we instill lidocaine for 30 minutes typically. Then that can help significantly numb patients up. It's tolerable. It's tolerable. And the Botox injection process is less than 10 minutes. So it's pretty quick. Yeah. So I have a lot of patients that are very happy with Botox. And then the other option that I do a lot of is called sacral neurostimulation. So you can actually have a pacemaker-like, I say in quotes, pacemaker-like device, small device that's implanted just underneath the skin in your upper back, the lower back, I apologize. And it has a stimulating lead attached to it that targets the S3 nerve. The S3 nerve, or the sacral nerve that is in our pelvis, actually helps control the bladder. And so that is approved to help control bladder or overactive bladder. It is also FDA approved for fecal incontinence too. So my patients, there are patients, and I always screen for this, that have some who have obviously overactive or urge incontinence, but also have some fecal incontinence. And so if a patient like that comes to me and we've tried medications, I tend to push them towards, for sure, this last option, or this option, because it can, I say it's like a 2-for-1. I can do this procedure that might help you on both ends. But certainly it is absolutely available for patients who just have overactive bladder without the fecal side of things. And it's a very, very minor procedure. This is not major surgeries. None of these options are major interventions.
Okay. All right. So, and it's very good to know, because again, especially the listeners who have these symptoms, that's always a big fear. Like, I don't want to have this huge surgery that may or may not work, and I become disfigured. And my men always think about ED, right?
Yeah.
And I'm pretty sure. Obviously, right? Like, so I'm just thinking, like, what are my men gonna ask? Because that's what they want to know. Like, is this a possibility that I can get ED after this? Right? Because if I got to deal with urinary incontinence versus ED,
I'll take the incontinence every time. Yeah. The answer is none of these are major operations, and they all have minor risks. Certainly not a risk of erectile dysfunction. That's the nice thing, is that there's, minor risk. I've operated on patients in their 80s, treated them with one of these options, the last one even. So it's out there. It is out there, and they're all FDA approved. They've been around for a very long time, actually.
And do you find that just I'm not sure popularity is the word, but the reason why most, especially, primary care doctors and just really the general lay people don't really know about those other things, is that they kind of get fixated on either medications or nothing? Or what would, because obviously we see the commercials about the overactive bladder, but we never see any of that about those kind of, especially the one in the ankle. Like, we never see any of those types of things.
Yeah, well, yes, it's not marketed. I think there are a few Botox commercials, but there certainly is nothing, there's none of the ankle, the PTNS, the sacral neurostimulation. Those aren't out there. So a patient won't know unless a doctor tells them, oh, this is out there. And I do think we as urology need to do a better job at communicating with our primary physicians on, hey, when you see a patient, let them know there's more that we can do for you, because the problem too is the patient drops out before they even can hear that there's options, or they even consider it. So you give a patient a medication, you tell them to go see a urologist. They're going to say, well, this medication doesn't work. What is the urologist going to do that's different? Give me another pill.
Yes.
I don't know of any other options. If they don't know, and then they just feel like, I'll just deal with it. But if you tell a patient, here, try this medication. If it doesn't work, guess what? There are other options beyond medications that might be available to you. So you tell them that the first time you see them, you've hopefully bought them into the process, that they have hope. Maybe this doesn't work, but there's other things. If they never know, they never know.
And for your patients who aren't necessarily dealing with the overactive side, but dealing with the stress side, the pelvic floor issues, what are those options that are out there for them?
So in that stress incontinence, which again, you perfectly stated, pelvic floor issues, it's a sphincter problem. It's not supported. And so when you do an activity, it transmits pressure or stress to your pelvis and urine leaks out because it's not supported anymore. Okay. And so all the options are designed to try to buff up or, support your urethra. So one option, which almost every patient probably knows about before they even walk in the door, is your Kegel exercises. Okay, so I tell,
are those effective? Is that
they can be effective. Yes, I mean if you have severe enough stress incontinence, it probably will not be effective. Okay. It also takes a lot of persistence and knowing what to do. So I will say probably half of women think they're doing or men think they're doing a Kegel and they're not. They're pushing, they're like bearing down. I tell patients, pretend like you're sucking something in. Pretend like you're holding in, this is very blunt, you're holding in a fart. Pretend like you're holding in a fart. If that sensation of like sucking it in that's the pelvic floor that you're contracting. And so there are physical therapists. So one adjunct to Kegels are incorporating pelvic floor physical therapists. Pelvic floor physical therapists can help you to strengthen up these muscles. And this can be a very notable improvement in a proportion of patients who have stress incontinence. It can also actually help with the first one too, the overactive bladder incontinence too. Beyond Kegel exercises and pelvic floor physical therapy, then there are more kind of deliberate interventional options. One, a non-surgical option is something called so for women, pessary, or a pessary for incontinence is a vaginal insertion device that's placed in the vagina in the office and used to support the urethra like a speed bump underneath it. And it's a device that the patient can learn to take in and out periodically themselves. So they can just wear it if they just need it for when they're going to the gym, put it in when they go to the gym so they don't leak, take it out when they go home. Or if they have it more consistently throughout the day, they can wear it in their vagina for days on end. And then take it out periodically once a week or at night or something like that. So it's a non-surgical way that can help patients.
And any issues with like safety, cleanliness or anything?
I mean, you can't, if you leave it in too long, it can cause a lot of discharge, which is unpleasant. It can also cause vaginal bleeding because you can get breakdown of the vaginal mucosa, like an abrasion. Like a pressure ulcer, if you will, but in the vagina. So that can cause bleeding. I don't have a lot of patients like that, but every once in a while I'll have a patient who's had a pessary in for like 6 to 12 months. And it's, it's like, okay, we need to just readdress this. So the risks are minor. I mean, that will heal if you just take it out. I will say pessaries for my young patients tend to be not that popular of an option because my young ladies are like, I don't want to trade my pads for something that I have to put in my vagina all the time. I want something where I don't have to do, actively. So then they may, and not to say just my younger patients, for a lot of my patients, but then surgery is an option. And the most common way that we treat this is by a sling operation. And a sling can involve mesh or can involve non-mesh material. But a sling is basically re-supporting the urethra like a hammock through a minor procedure that involves a small cut in the vagina and sometimes some additional cuts in the groin or the belly. And we re-support the urethra with this kind of tape-like product. Again, that tape can involve mesh. I do a lot of slings. It has a very high success rate. And in some patients, they may opt for what we call an autologous sling, so that they use part of their own tissue instead of mesh to form the sling that we use to then support the urethra. That procedure is more involved and definitely more invasive because we have to cut them like a C-section scar and get a piece of their tissue that way before we even do the sling. But that's one of the main options. There's a procedure that we don't often do, but it is also can be done, is called bulking, urethral bulking. Think about fillers, like plastic surgery. They put fillers in people's cheeks to bulk it up or plump up their lips or whatever. You can do fillers in the urethra almost with like collagen is one example of a product we use for bulking that can bulk the urethra so that it provides resistance so that there's less leakage with activity.
Oh, okay. All right. Like, I can see that. Like just more pressure to, okay.
Yeah. Plumper urethra that's kind of causing more resistance. Yeah. That's
interesting. I guess the flip side, and I'm just asking as a physician, like would that lead you at a risk for like some, maybe like urinary retention then? Like would you go the opposite way if you?
Sure. Okay. Yeah, all of this is an art. You can have urinary retention is a potential risk factor for any of these options because we're re-supporting the outlet. So absolutely, yes.
Sorry, I want to learn community. I like to. Yeah. I'm getting just as educated as you guys. I'm like, I wonder if they do that, then I wonder if they didn't come back to me like, hey, doc, I can't even pee anymore. Like,
we talk about that for the men. So those were options for women. Mm-hmm. For the men to be complete, not leave you the fellas out.
Yes.
For the men, same thing. Physical therapy, Kegels. Men have Kegels too. Beyond that, there are.
May I hear that? Like, of course, if my men tell me that they don't work for us, right? That's just a women thing.
It's harder to explain. It's harder to teach a man how to do a Kegel. In my experience, I will say that it can work, but it's harder to teach. Yes. Beyond Kegels, the non-surgical option for this cough, laugh, sneezing, leakage, or stress incontinence, it's going to sound like a medieval torture, but penile clamp. It sounds terrible. I know.
Let's go.
But it's not as terrible as it sounds. It's actually like a cushion. They have a cushion, and it's think about it. It's like a clamp that goes on the outer part of the penis. The urethra goes through the penis. So if you clamp just along the shaft, it can cause resistance so that you don't leak when you're playing golf, or the man doesn't leak when they're coughing, or they're going to the gym, or going for a walk with their dog. And so penile clamps can work in some patients. Beyond that, we have slings for men. There is a male sling. So just like women can get slings for this, a male sling product is out there that does the same thing, re-supporting the urethra like a hammock. And then for men, one of the more unique options that they have is something called an artificial urinary sphincter. And that's basically an artificial device that looks like a little mini blood pressure cuff. And that little mini blood pressure cuff we put around the urethra, and that causes the urethra to be closed at rest. So the urethra is closed, so you're not losing urine when you're out and about doing things. But then when the man wants to urinate, they obviously need the urethra to be open. So part of the device has a concealed pump in the scrotum. This little pump that's in the scrotum, the man goes, pumps this pump in the scrotum, and it opens up the cuff so that the man can pee. And that's been around since the early 1970s. And that is the gold standard, surgical gold standard for treating male stress incontinence.
I was going to ask, which one do your men typically?
I do a lot more of the artificial urinary sphincter.
Okay.
Because by the nature of, it has more data behind it. Most of the men that I see with that are pretty severe. Mm. So the male sling is good for patients who have mild to moderate, but for patients who have severe, more than 4 pads a day, and patients who've had radiation. So again, male stress incontinence tends to be somewhat of a unique group because most of those men have had treatments for prostate cancer or some sort of prostate-related procedure. And so I would say probably half of the men I treat, they've had radiation for their prostate cancer treatment, and the male sling has been shown to be less effective in that group. So,
and I know a lot of our conversation, especially for Lunch Learning community members, may have us leaning like all you're seeing is people over the age of 60, right? Like what is some of the age range of people who are walking into your office and your clinic with these similar complaints? Like what are some of the age ranges that you're seeing?
All over. all over. I will say, obviously, incontinence as a whole tends to be more prevalent as the older we get. In women, it peaks, it gets higher at menopause, and then starting at menopause, and then steadily gets higher with every decade. Same with men.
Why menopause? What is? That's interesting. Okay.
There may be some estrogen related changes that make incontinence more of a risk. So we don't know it. I don't think we understand it completely, but we do think that hormonal status may play a factor. But in any case, I've seen young patients with incontinence. I mean, young people, even kids, can have overactive bladder. I see patients who say, I've had this all my life, but I've just secretly dealt with it. And so that, again, I tell people overactive bladder is equal opportunity, condition, young, old, men, women. I have seen young women. We do think that high impact exercise or sports can increase the risk of stress incontinence in young women. So I have seen a handful of patients in their teens who are super athletic. Oh, I'm on the cross country. I play volleyball. I'm in track, that have cough, laugh, sneezing, exercise, and do leakage. Track player, every time she runs and she jumps on the hurdle, she's squirting out urine unintentionally. Never has been pregnant, never has had any kids, nothing that you would, those common risk factors that you would expect. Super skinny, very athletic built, but has this incontinence. So it can affect even the young people.
That's very important to know, especially as a primary physician, because I can tell you that question is probably not even in my armamentarium when I think a person is young. Like why, especially as a primary care doc, why would I ask my 20-year-old, my 25-year-old, like, oh, hey, you ever had any problems like dribbling? Or I don't even think that would even come to mind. So that's definitely good to know. Yeah. To make sure that's a question I gotta, oh, hey, by the way, ask them about this just in case, especially if you're saying there, a lot of people are walking around, I had this all my life and just more embarrassed, but I'm pretty sure if a physician, someone like a primary would have said hey, any problems urinating? Right? They probably be like, oh, doc, I've been waiting.
You're absolutely right. You're absolutely right. They're waiting to tell somebody, they want to bring this up. They just don't know how. They probably think, especially if you're young, you probably think, gosh, I must be the only person that has this. Why am I so young and dealing with this? I'm too embarrassed to even tell my doctor. So, yeah.
Interesting. So for especially because we've heard the kind of the gamut, right, from start to beginning, right? Is there any way, right, that I can even prevent this? Is there anything I can do to, I guess, avoid seeing you? What is there any process I can start now and say, all right, maybe if I do this, I can avoid seeing urologists when I get older?
So healthy living, healthy diet are always good things because weight is a factor, okay? And certain foods and drinks can increase incontinence. So I tell patients, ditch the sodas, okay? Soda is just Coke, sodas, pop, whatever region that you say it. I say soda because that's what I grew up saying, but everybody says pop here in Chicago or Illinois. So pop, soda, Coke, ditch that. Make that for special occasions only. Don't, same thing, don't moderate coffee, tea intake. I personally used to be a big coffee drinker, got to residency, and it was causing me to have overactive bladder. I had to go all the time, very urgently. So I had to give it up because I just didn't have time. So doing that, dietary modifications can help avoid it. Even patients I've heard women talk that are pregnant, well, I'm not going to have a vaginal delivery because that is worse than having a C-section. And that is true. Probably vaginal delivery might increase the risk, but guess what? Even with a C-section, just by having a pregnancy, carrying a pregnancy, even with a C-section, you can have that risk of the stress incontinence. So I don't generally advocate for patients to choose one method over the other just because of that. Okay. Yeah.
All right. And before I let you go, I obviously have to, kind of delve into the fact that, fortunately, you had that one Black urologist who came to speak, right? Just maybe by chance, maybe by not. and that kind of, led you like in the direction, right? When you're going in this process of becoming a urologist and you're starting to realize like, oh, wow, there's really not a lot of women here. And there's definitely not, and I mean, this goes for medicine in general. There's definitely not a lot of Black women in here.
I was going to say, I knew that before I even got into the process.
Exactly. You don't even have to tell me. I'm almost sure like, oh, there's not a lot of women. I already know like the number of Black women is even smaller. Like what's that process been like? Just, and again, as a urologist, right? As a female urologist, and patients are coming to see you and you're like, whoa, like do you ever like experience like, oh yes, like I'm definitely glad that I was able to kind of go this route, or like, wow, it's crazy that I was able to go this route. Like what's been the process like? Well,
number one, representation matters. For me, it changed. I would have never thought about this field, and I love this field. I would do it. I would pick it over and over again if I had to go back and choose it, 100%. So for me, the big thing is replicating that and trying to be visible on social media, or, mentor people, or get out there and talk to young people, say, hey, maybe it's not a urology, but you could be, ophthalmologist, you could be a plastic surgeon, you could do orthopedics, okay, as a woman of color. I would say going through the process, fortunately, has been majority of the time been a pleasure, okay? People ask me, well, how have you been received by maybe your attendings or your colleagues? And I will say I trained at the University of Chicago, loved it. I'd like to say and think that I was one of the favorites. But yeah, it was a very welcoming environment. Absolutely. We celebrate diversity where I trained. And I would say, fortunately, majority of institutions are more want to have that diversity, and are as a specialty, we as the American Urologic Association, we publish the numbers of women who matched. We love that. We want to show people out there like, yay, there's more women that are getting in the field now. So it's been very positive. Some patients are definitely timid, more from the gender side of things and the race side of things. Personally, I can think of a handful of patients who flat out definitely were like, you're not touching me. I don't want a woman, urologist treating me. And, it's your loss, boo-boo. It's not mine. You won't be able to experience the fabulousness that is me, okay? And I've had a few unfortunate, like racial, patients who did not want to be treated by me because of my race. And you know what? I sleep great at night.
100%.
Because I know my skill. I'm sure you have stories too.
Oh, yes.
But again, by far, it is such a pleasure. The sisterhood in urology is so tight and so good. I mean, we have there's not a lot of us. So we all have like the same stories. We have a certain personality of just, being there for each other because we know what it's like to be surrounded in a very male-dominated specialty, in a boys' club, if you will. And then the few of us Black women too, or, and then there's actually a Black urology community too, definitely tight-knit. There's a even tighter knit Black, women urology community. Not a lot of us at all. So I'm very fortunate and feel very privileged.
And what are some of the numbers again? I'm sorry, just can I give
8-9% women in practicing in urology. Yes. Wow. One of the lowest specialties that have it. It used to be the lowest. I don't know if it's the lowest still. But it is definitely top, at the bottom, top 2 or 3. Wow. And Black urologists, ooh, baby, 2% maybe.
Wow.
Yes.
And the reason why I shake my head at that is that understand, especially that from a numbers game, that a lot more women are going to need to be seeing urologists. But the fact that 92% of the field is dominated by men, I can only imagine from the patient side, right? Because obviously, lunch learning community members, a lot of them are patients, right? Fortunately, they better be patients because they better be going to their doctor, right? I can only imagine being a woman and wanting to see a female urologist and literally not even having that ability to do so. Like, depending on where you're at. Look, I'm in South Florida. So, in fact, it's so funny. We have one of our urologists. I love her, Dr. Lobby. She actually promotes herself as the female urologist, right? Like,
yes.
like that's her thing. Like, she does not see men. Like, she's like, she's like, I don't see men. Like, and I said, like, is like, can you? She's like, yeah, I can, but I don't want to.
You can't.
But she's like, nope. And people know her. Like, my patients, especially my female patients, will come and be like, oh, I need to see Dr. Lobby. And I'm like, oh, how you know about it? Well, she's a female urologist. Like, why wouldn't I see? Like, to the point where I don't think my patients realize men can handle the stuff that they have. Like, 'cause she's done a great job in her advertising. Shout out to Dr. Lobby. Shout
out to that. I agree, right? You're absolutely correct, though. So when they see that there's a female urologist in their community, the doors go busting wide open, you know? So absolutely. I have a female partner in my group, and she's awesome. She's excellent. And she was the only female urologist in this massive group of ours until I became the second one. And she actually was really happy to have me come along. She's like, I wouldn't mind having a little bit more diversity. I was like, I do want to see the men too. So maybe you can take some of the women so I can see some of these men again. Yeah. So
No, again, I was thinking, especially from the physician side, but even worse from the patient side. Like, if I like literally did not have like, maybe I feel more comfortable seeing, and again, I don't want to assume that you would feel more comfortable, but maybe I would feel more comfortable seeing a female urologist, but I don't even have that ability because it's not wow,
it's
90,
not there.
90, wow. Okay.
Yes.
All right.
Yeah, we live in like, you know, decently sized big cities, right? So the chances are you might have a woman urologist somewhere in the vicinity. But there's tons of communities around the United States that they're not there.
Not there, not having a choice.
Yeah.
Okay. Before I let you go, I definitely want, you know, people to be able to obviously follow you. First of all, like, side note, you're absolutely amazing. I recently started following you on social media. Absolutely amazing.
Thank you.
Amazing person to follow, especially because you do like me. You do like a lot of fun stuff, but you do a lot of teaching stuff, which is always good, right? Because I think we need way more physicians like out there, like to combat some of the craziness that, you know, that's out there on the internet. So I love seeing our experts out there saying like, no, this is what it is. This is the education. So where can people follow you, find you? Especially if they're in the Chicago area, you know, get into your practice. Like, give us all that information. Let us.
Thank you so much. First of all, I love my Instagram page is where you can find me. That's my personality. So it's at Dr. Milhouse, and Milhouse is with one L. So at DrMilhouse, and on Instagram. And my Instagram is definitely, you're going to learn urology, but you're going to see my real life. You're going to see like my personality, you know, motivation. I really have found that my Instagram is not only for my patients to find me and to learn about me, but also for young students, college students, medical students, residents to be inspired. And I've been able to reach out to so many students from all over, from all the way back home in Nigeria, all the way in the Caribbean, the way, you know, college students who want to be doctors. So absolutely, I'm an open book. If you have something you want me to talk about on Instagram, just send me a message. And then my practice is Dupage Medical Group. So our website is www.dupage, DUPAGE, medical group, all, you know, obviously one word, .com. Okay.
And you can community members, I will have this in the show notes as well. So you don't have to like write it down. I will have her links in the show notes for you guys.
Excellent. Yeah. Thank you so much. It's been fun.
yes. And no. Thank you for, you know, again, educating our community, educating me. Right? Like I said, I'm already mentally adding questions I need to like start like incorporating, especially for, again, I'm sorry, younger patients. I forgot about you guys. I really thought this was an old person's issue. Right. And like, I didn't think you'd be young enough to deal with it. Clearly you are. Yes. And I definitely want to make sure that we're addressing it so you're not walking around in your teens and in your 30s and your 40s with this problem that you've always had, that you just wished somebody would have said like, hey, by the way, what's going on? Like, can you pee correctly? And then go from there.
Exactly. Yep. Wonderful. Well, I'd love to be be back on the show. We can talk about something else.
I love to hear
We can talk more for the men.
Yes. I mean, my men, and I'm pretty sure you already know, my men are scary. Men are scary when it comes to anything. Because they always, I don't know what happens in the urology office that they've seen on TV, but like, it's always like, oh my God, I don't want to be on this table. I don't want stuff stuck. Like, they just don't want things stuck in them. Like, it's just it's
the image of the like big man with the glove, snapping the glove and then, doing the rectal exam.
Yes. So total fear of it. Right. Yeah, well, Dr. Milhouse, thank you for an amazing episode. And like I said, Lunch Lane community members, please follow her. Amazing person to follow, to have a good time laughing, to be educated, right, which is always a plus for me on both sides.
Yeah. Thank you so much. Have a great one. You take care of yourself.
Thank you for coming to the end of the episode. It is yours truly, Dr. Barry Pierre. I want to give my undying thanks to you for your support. Just getting to the end of the episode means that you at least enjoyed today's episode. Hope you were empowered by today's episode. Please remember to share this episode with at least 2 people that you know that would be greatly affected if they did not listen to today's episode. And if you have not already done so, subscribe to the podcast. Leave us a 5-star review, especially on Apple Podcasts or wherever you can leave a review. Leave a review there because your support is so valuable for what we're doing here on the Lunch Learn and everything with Pierre Medical Consulting. And if you have not done so, go ahead and join the listserv. To join the listserv is very easy. Just grab your phone right now. I'll pause. Join the listserv. You want to text Lunch Learn Pod. This is all going to be one word, Lunch Learn Pod, to 44222. And you'll be on the listserv. You'll know exactly when new episodes are coming out. You'll know about new episodes before they actually come out, because I usually tell my listserv members, hey, this is what I'm working on. These are the guests that you should expect to hear for the week on. Thanks, guys. You have a blessed day, and I'm going to see you guys next week.